So we'll just do a quick run through of what we're actually going to do in the lab in a second. So I think it's, as Adrian said, it's really important that we do get in and start doing some of the practical stuff. So I'll just do a very quick background about some of the key facts about rotator cuff tears, and then about the main steps and how we're going to repair them today, because there are lots of techniques that we can employ. Okay, so essentially they're a very common problem, and as Adrian said, actually the majority of rotator cuff tears that we see are actually probably degenerate. It's about 30% of people that are over 60 have rotator cuff repairs if you were to see them all on radiology, and it's about 50% in the over 70-year-old. They don't all need to be repaired, but we'll talk a bit about that in a second. So risk factors are age, smoking is also a risk factor, and also family history. So your pathophysiology, they're either chronic degenerative. So the chronic degenerative ones tend to be an intrinsic tendinopathy, and they tend to cause articular-sided tears first and then progress to full-thickness tears that way. You can also have chronic impingement, which can cause bursal-sided tears, and the bursal-sided tears tend to progress a bit quicker than the articular side. And of course, in the context of sports injury, acute traumatic tears, which in acute sporting injuries tend to be bigger tears. However, you can have a chronic tear or a chronic impingement background and then have an acute or chronic picture. Okay, so just talk a bit about the insertion of the rotator cuff. So you've got your supraspinatus is there a pointer on this?
It won't show up on the screen.
No worries. Okay, so this is obviously a cadaveric model of a rotator cuff insertion. So you've got your supraspinatus inserting into the anterior part of the greater tuberosity, infraspinatus into the posterolateral part of the tuberosity, teres minor coming down here, and then your subscapularis is the bigger tendon at the front. Okay? So the actual width of your insertion here is about 13 to 14 millimetres from the articular side to the outside of the greater tuberosity, and your AP diameter here is about 2 centimetres, including both the supraspinatus and infraspinatus. The subscapularis is actually the bigger insertion footprint, and there's about 17 millimetres of width of the subscap. So why do we actually repair the rotator cuff? So I think we need to talk about the function of the rotator cuff. So overall, the function of the rotator cuff is to provide dynamic stability of the glenohumeral joint through a balanced range of motion. So you can have small tears in the rotator cuff which are still balanced, and they don't necessarily cause symptoms, they may not progress, and therefore they may not need treating with arthroscopic or open repair. However, if you start to get imbalance in the rotator cuff, so the tear begins to progress, it doesn't respond to conservative measures such as physiotherapy or physiotherapy plus or minus injections, it will lead to pain, loss of function, and potentially progressive degenerative changes in the joint. And of course, they're the people that we need to identify to try and repair. Yes. Okay. So we've got a very small part about the classification, so there's lots of ways that they can be classified. Small, medium, large, massive, just think 1, 3, 5, 5 plus, okay? For thickness, we talked a little bit about partial versus full thickness. So your partial thickness tears can be either articular-sided or bursal-sided. The bursal-sided ones actually tend to progress a bit more quickly, so you have less of a threshold to repair here. With full thickness tears, partial articular-sided tears, there's an arbitrary number of 50%, so if you get 50% off uncovering of the footprint, it's basically when you start to repair them. However, you also have to take that in context with the activity of the person, the quality of the tendon, and the function of the person. Okay. And obviously full thickness tears. So you can also talk about the number of tendons. If it's more than 2 tendons involved, it's deemed a massive tear. Then we talk about shapes. So a crescent side, I'll show you a picture of it in a second. Crescent, a U-shaped, L-shaped, or a massive contracted. So with the crescent shaped, it's just essentially quite a small crescent, usually in the supraspinatus, underneath that cable area. U-shape progresses more medially, however, it still might be balanced front and back to anterior and posterior. The L shape, one of the arms of the tendon is more mobile than the other, and they can continue to progress a lot quicker. And then the massive contracted tendon tears are the ones that are often irreparable. Okay, just a quick little view of that. Right, okay. Other thing just to mention before we go on to the steps of how to repair them, which we'll go on and do. Factors that may make your tendon tear either irreparable or the prognosis of that repair poor. So there's something called the Gutaye classification, which is actually originally described on CTs, but we do it more on the MRI now, using the sagittal imagery. So you've got your coracoid at the front here, your scapular spine here, and your scapular body here. So your supraspinatus fossa, infraspinatus fossa coming down into teres. And this is the subscapularis here. So you can see the amount of fatty infiltration in these muscle bulks here. The Gutaye classification essentially is as follows. And essentially when you get to the point where you've got equal muscle to fat or worse than that, the prognosis of repair is okay, so repair technique. We'll just talk about the steps and then we will go in and do all of that. So it sets up, George has talked us through and Livio's talked us through really nicely. I do tend to use the beach chair position, I do use adrenaline in the first few bags, and I've only started doing that in the last few years, and that's allowed me to drop the pump pressure down, which actually reduces the swelling and hopefully is speeding the operation up a bit. I also do use the arm positioner. The Tremano is the one that I use, however there are a number of others on the market, but you can also just use simple traction using a couple of saline bags over a drip stand. Portals, your standard viewing portals, so standard portals posterior and anterior. And I think it's important, as Livio mentioned earlier on, your portals depend on what you find in your diagnostic arthroscopy. So it kind of depends on where your tear is. If your tear is very anterior, it may well be that you're using just your supralateral portal, your anterior portal, and your posterior portal, and that might be enough to shuttle your sutures through to repair it. However, generally, when I'm doing a rotator cuff repair, I'll definitely use the posterior, anterior, and supralateral, and then a lateral and posterolateral depending on where the tear is, but we can look at all that inside. Okay, so the steps, diagnostic arthroscopy we've gone through, and the next really important thing is you need to delineate the tear, you need to work out how big that tear is, you need to work out how retracted the tear is, and is it mobile, and therefore is it repairable. Okay. If you've decided that it is repairable, I go on to then do a subacromial bursectomy, and you need to do quite an extensive subacromial bursectomy to clear the area to make your working view and your life easier. You need to debride the tear to a stable edge, and then think about doing either releases, plus or minus margin convergences to kind of depending on the type of the tear. So with releases, you can do both intra and extra-articular releases. So your intra-articular release is above the glenoid and underneath the rotator cuff margin there. Your anterior release over the top of supraspinatus and posterior release out to the back of the scapular spine. You've got to be careful of your suprascapular nerve. Once you've done all your releases, then do my footprint preparation. I use a soft tissue shaver to start with. However, if needed, I will use a burr to make sure that you get some bony bleeding to improve healing. So, tendon repair, there are a number of ways of repairing rotator cuff tendons. However, I'm going to talk mainly about a double row technique because that's what we're going to be doing in here. Place your medial row anchors, then pass your sutures through the tendon. I cross over the sutures and then incorporate them into a lateral row. And then I do the acromioplasty at the end generally, although sometimes if you've got very little space in your subacromial space, you might do the acromioplasty first. Okay, so just to go through that a little bit more pictorially. So this is where I'm talking about margin conversion. So if you've got a big U-shaped tear, if you were to just put your medial row anchors here and then try and pull the tendon all the way over, the tension on that repair would be completely excessive. So what you need to do is try and shut that gap down a little bit first by using some margin convergence, and then it becomes a simple. Okay, and this is essentially just, it's not the best picture I'm afraid. So the articular surface is in here, it's not my picture, and this is your footprint here. And this is just a picture after after you've debrided all the soft tissue, you've got some nice kind of bony bleeding there. Okay? This is a picture of two of the medial row anchors. So here's your articular surface. So your medial row anchors, I'm assuming this is a simple 4 anchor repair. Okay? So good space between the 2 anchors. You need the anchors right at the margin of the footprint and the articular surface, and I angulate them 45 degrees into the humeral head. Okay? Use loaded anchors on the medial row, and then use a suture passer to pass the sutures through the tendons. Then cross them all over. This isn't quite the same as that one. And then use another 2 anchors laterally to incorporate the tendons. And you can see that that brings the whole tendon down, it covers the footprint, and hopefully gives you a good tendon healing. Okay, that's just this is the actual these are the anchors that we're going to be using next door. So this is the Arthrex speed bridge repair. Okay, so double row versus single row. Okay, so there's a lot of literature out there. However, clinically, there hasn't necessarily been any big studies to suggest that double or single are better. Biomechanically, the double row is better at getting footprint cover. You get less gapping, you get less re-tears, and it's biomechanically stronger. However, sometimes you can get less tension on a single row repair because you're not having to pull the tendon over quite so far. And in some people's hands, it's a lot quicker to do a single row repair. So these are things you need to balance. And it may be, for smaller tears, a single row repair is appropriate.
What do you guys do out of interest, the faculty here?
I personally tend to do a double row repair in the majority.
Right.
For small tears, I might use just one anchor single row.
Yeah.
Same. Yeah.
Okay. Shall I run this video now?
Yeah.
This double row rotator cuff repair
So
combines a fully
these are the actual
framed
implants you're going to be
swivel-lock
using.
fiber tape to create a strong and low-profile construct while minimizing surgical steps.
Okay, so this is preparing
The
footprint,
rotator
getting
cuff
rid of.
footprint is prepared.
Actually, he says it all, shall I just shut up?
The arthroscopic lateral viewing portal and a bone socket is prepared at the articular margin. The swivel lock is available with a convenient preloaded fiber tape loop. The swivel lock is inserted by holding the thumb pad steady while rotating the driver handle. The preloaded fiber tape loop is released from the thumb pad and the number 2 fiber wire tip retention suture is discarded. The fiber tape is retrieved laterally. The fiber tape limbs are joined into a single tail to allow easy passage with a fast pass scorpion, which automatically retrieves the passed suture. Fiber tapes are moved to an accessory portal and the process is repeated with the second medial anchor. Trim the fiber tape loop and the splice to separate the tails. Retrieve 1 fiber tape from each of the medial anchors. Preload the fiber tapes into the swivel lock. Prepare a lateral bone socket. Tension the fiber tapes and then insert the eyelet into the bone socket. Do not attempt to apply tension with the eyelet in the bone socket. If it is determined that the tension is not adequate, the driver can be backed out and tension will be adjusted. Insert the cannulated and vented biocomposite swivel lock anchor. If a dog ear is anticipated, it can be reduced using a fiberlink suture passed in a cinch stitch configuration. The fiber link and 2 remaining fiber tape tails are all secured with a second lateral swivel lock anchor. This completes the totally novel speed bridge repair, which enhances footprint compression to maximize tendon to bone contact.
Right. Okay, so that just gives an overview of how to do a simple double row repair. See, in the scope of this talk, I haven't talked about every single type of tendon tear or repair that you do. I haven't talked about subscap repairs. However, what we're going to be doing next door is this technique. Okay, there are many anchors. However, we are using the Arthrex anchors here today. So I think we should.
It include a bit of it.